This presentation is adapted from Pulmonary, Sleep, Cardiology, and Critical Care Academy, an online CME-accredited course for advanced practitioners and physicians. Today, I'd like to provide you with an overview of hepatopulmonary syndrome.
So hepatopulmonary syndrome. In hepatopulmonary syndrome, we have an oxygenation defect related to pulmonary vascular dilation in patients with chronic liver disease. Dilated pulmonary capillaries and pulmonary pleural AV communications, possibly all related to secondary increase of nitric oxide production from the liver disease, leads to these abnormalities. The AA gradient is a more reliable indicator of oxygenation problems than the PO2. That's because there is hypocapnia, which partially corrects the PO2. So the PO2 doesn't look as bad as it would have if there wasn't hypocapnia. Remember, there's reciprocal increase of oxygen when the PCO2 is low and vice versa. Anyway, patients with chronic liver disease are hypocapnic, so it's best to look at the AA gradient rather than the PO2 itself. Symptoms of hepatopulmonary syndrome are dyspnea, which can also be confounded by ascites, anemia, and malnutrition with muscle dysfunction, and the very interesting symptom of platypnea. Platypnea is the opposite of orthopnea. Remember, in most patients, when you lie down, your breathing is worse. You have the effects of the diaphragm pushing by your abdominal contents. So heart failure patients and neuromuscular patients get worse laying down. Platypnea is the opposite. Patients are relieved, their breathing's relieved laying flat, and they're worse sitting upright. And the reason platypnea exists is that these vascular abnormalities I just mentioned at the top are prominent at the lung bases, so that when you sit upright, a larger fraction of your cardiac output goes to the areas of the shunting, and the shunt fraction paradoxically worsens when seated upright. Signs of hepatopulmonary syndrome are interesting. Cyanosis because of shunting, clubbing, spiders, severe hypoxemia, orthodeoxia, which is the sign that correlates with platypnea. When someone moves from supine to upright position and they say they're more short of breath sitting upright, when you diagnose platypnea, you should check their saturations. And if they drop more than 5% on assuming an upright position, they are then found to have orthodeoxia. And that's pretty specific for hepatopulmonary disease, or at least orthodeoxia suggests that there are dependent shunt areas in the lung. Another sign of hepatopulmonary syndrome is portal pulmonary hypertension, which is a form of type 1. Oh, I said that wrong. I'm sorry. A form of group 1 pulmonary hypertension. The final sign that we see is an isolated low lung diffusion capacity. I created an interesting slide for you to look at that explains why the diffusion capacity is low. We'll look at that in just a minute. But what I mean by isolated is the lung functions are otherwise preserved. We see normal flow, normal lung volumes, but the diffusion capacity stands out. Typically, completely normal lung functions, and then the diffusion's at 50% predicted. That's what we mean by isolated. There's no direct treatment for hepatopulmonary syndrome beyond liver transplantation. So here's some images of how we try to diagnose. This is a contrast-enhanced bubble study of the heart. And in the first frame, the patient was injected with agitated saline that had a lot of bubbles in it. And right after they injected, they did an echo as they were injecting, and they saw the bubbles all collecting in the right atrium, but not quite in the RV. Now, within 1 or 2 squeezes of the RA, the contrast from the bubbles filled both chambers. But notice how there's no pathway in healthy people for the bubbles to get into the left side. Now, there are some abnormalities that can create right-to-left movement. One way is a hole in the heart, either an ASD or a VSD or a PFO, a connection. And if that's the case, we'll see the bubbles get to the other side within 1 or 2 cardiac cycles quickly. The other way is for the bubbles to get through the the lung and come out on the other side into the through the lung, which is up here, through the capillary bed, and come back to the left atrium, take the circle around, and get into the left side. Now, in this case, you could see that the bubbles did make it around, but this was 5 to 6 seconds later. So we know, because of the delay in seeing the bubbles, that the bubbles had to go through the lungs and come around. Just as I mentioned, if this was an intracardiac shunt from a PFO or an ASD, we would have seen the bubbles move over within 1 or 2 cardiac cycles, not 5 or 6 seconds later. So this is a classic echocardiogram of delayed shunting of contrast, in this case bubbles, to the other side of the heart. Another place we can look is a lung perfusion scan. We use technetium-99 labeled macro aggregates of albumin. What happens in a healthy person is the albumin that's radioactive stays in the lung, and they can't get through the lung because the caliper of the albumin aggregates are too large to fit through the capillaries. Now, the real reason we usually do a perfusion scan is to look for defects that would suggest a pulmonary embolism. This patient does not have a pulmonary embolism, but it's a useful test to see if these macro aggregated albumin can get through the lungs, meaning that there's some sort of an opening. So in this patient, there's excessive uptake in the brain, which means that there's some sort of dilation of the blood vessels, allowing these to get into the systemic circulation. The radiologist will make a ratio of how much of the radiotracer is systemic versus the lungs. They don't want to count the kidneys, but a normal value is under about 4%. This patient might be 25% became systemic, meaning that there's some sort of small vessel dilation allowing these macro aggregated albumin to get through the lung. Finally, digital clubbing, and here's an impressive case, is a prominent part of hepatopulmonary syndrome. And in the last year, I've actually seen 2 patients that have had digital clubbing from this disorder, including the young patient I used at the beginning of this talk as a case study, the 35-year-old that had hepatitis C and wound up having pulmonary hypertension and right heart type 1 PAH. I'd like to use my diagrams to demonstrate the mechanism of hypoxemia in hepatopulmonary syndrome. Let's take a look at a normal patient so we'll better understand the abnormal patient. In a normal patient, all of the lung zones are very homogeneous. The blood vessels are normal caliber. Purple, which I'm indicating is deoxygenated blood, comes in to the pulmonary artery, and as it goes through the capillary bed, from all lung zones, it becomes fully oxygenated and comes out at 98%. Now, in hepatopulmonary syndrome, there can be some regions where the purple blood comes in deoxygenated. The blood vessels are not dilated. This is the normal distance I indicated in green, and it comes out well oxygenated. That would be one zone. But there are other problems, so let me demonstrate those. Here's a dilated blood vessel. So now the pathway from the capillary membrane, from the alveolus through the membrane, through the capillary endothelium to some of the red blood cells is a much longer pathway, and that leads to incomplete oxygenation. I mean, there's some oxygenation. It goes from purple partially on the way to red. I used a lighter purple to indicate that. So you already have the dilation contributing to our problem with oxygenation. But then there's the second problem that has to do with the shunting. Let me show you that here. So the shunting is represented by an arterial venous connection that bypasses the capillary bed completely. These are the little spiders that are in the dependent parts of the lung. It truly causes shunting. What a shunt is the blood just bypasses the capillary network completely, so it has no chance to pick up oxygen. And in this case, it's a large contributor to the final mixing of all of these regions, and that's how we get a quite low saturation.
If you'd like to learn more, please visit our educational center at pulmonaryandsleepacademy.com, where we have 70 hours of self-paced online CME-accredited courses covering pulmonary, sleep, cardiology, and critical care medicine. Please enjoy more of our short visits on our PSA YouTube channel. You can purchase our full courses with an exclusive 10% discount code using YouTube10.